Hi, and welcome back to American CME's Patient Assessment Series. This is part 2 of our 3-part series. My name is David Mills, firefighter paramedic, and today we will be discussing the initial assessment portion of patient assessment. Our objectives today are simple. By the end of this video, you will understand how to conduct a thorough initial assessment, as well as the importance of a thorough and complete initial assessment. Once we have completed our scene survey, we can now move on to the second component of patient assessment, the initial assessment. Scene survey helped us to identify what we have and call upon what we need to render proper care. During the initial assessment, we will find and fix life threats, if any, by taking corrective actions in order to aid our patient. Simply put, the initial assessment is an organized way to recognize and respond to potential life-threatening conditions that affect our patient. An initial assessment consists of 5 subcomponents that include forming a general impression of the patient, an assessment of the patient's level of consciousness, addressing the chief complaint, evaluating the patient's airway, breathing, and circulation, and making a patient priority decision. The first step of the initial assessment is to form a general impression of the patient. The key word to consider here is synthesis. When forming a general impression, we must synthesize relevant clues which, when considered together, begin to move us down the path of uncovering the underlying cause. Relevant information may include the patient's appearance, which social group they belong to, and the context or setting the emergency has occurred in. It also includes the patient's approximate age and gender. How the patients appear can indicate the severity of the emergency and clarify its medical nature. Appearance is extremely critical to forming our general impression, and I'll illustrate why. You receive dispatch information which states a patient is having difficulty breathing. When you arrive, you find the patient sitting comfortably in a chair while not appearing to be in any distress. Now let's imagine we receive another call. Again, a patient having difficulty breathing. But this time, when we enter the room, we see a patient struggling to breathe, very pale and diaphoretic. These 2 patients had the same dispatch information, but 2 very different general impressions based on appearance alone. In this case, our general impression instinctively arouses an appropriate response of urgency or non-urgency. Immediately following the care provider's general impression is an assessment of the patient's level of consciousness, or LOC. The patient's LOC should be evaluated based on the acronym AVPU. The AVPU scale is a system by which EMS personnel can measure and record a patient's level of consciousness. The AVPU scale has only 4 possible outcomes for recording that will indicate the degree to which the patient is alert. The 4 possible recordable outcomes are alert, verbal, pain, and unresponsive. Each of these will signify what stimulus the patient is alert to. When a patient is considered to be alert, they are fully awake. These patients will have spontaneous eye opening and appropriately respond to voice. Here you can see a patient that responds appropriately and is considered to be alert.
Good morning, sir. How are you feeling today?
I'm not feeling good.
When a patient is considered to be alert to verbal, the patient makes some kind of response only when you talk to them. The patient's response when alert to verbal could be in any of 3 component measures, including eye movement, vocal response, or motor function. An example would be when a patient's eyes open after being asked, "Are you okay?" The response could be as little as a grunt, moan, or purposeful movement of a limb when prompted by the voice of EMS personnel.
Sir, how are you doing today? Sir?
A patient who makes any type of response when a painful stimulus is applied to them is considered to be alert to pain. Recognized methods for applying a painful stimulus include squeezing a trapezius muscle, or most notably, performing a sternal rub. When applying a painful stimulus, a fully conscious patient would normally locate the pain and push it away. However, a patient who is not alert and who has not responded to voice is likely to exhibit only withdrawal from pain, or even involuntary flexion or extension of the limbs from the painful stimulus.
Sir, can you hear me? Sir!
The person assessing must always exercise care when applying painful stimulus as a method of assessing level of consciousness. Our goal is only to assess the patient's LOC, not injure them. The last possible outcome, unresponsive, is sometimes seen noted as unconscious. When a patient is considered to be unresponsive, they do not react with any eye, voice, or motor function to verbal or painful stimulus when applied. Here you can see a patient that is considered to be unresponsive. If a patient is alert, evaluating whether or not they are oriented will further assess their mental status. Typically, patient orientation is established based on testing their ability to recall their name, the date or approximate time of day, and where they are. When they can answer all of these questions correctly, they are said to be alert and oriented times 3, or ANO times 3. If they can answer only 2 of these questions, then they are ANO times 2. If they can answer only 1, then they are ANO times 1. And if they cannot answer any, then they are ANO times 0. Now this brings me to my next point. Too often, care providers patronize patients with unnecessary orientation questions. Care providers can sometimes lack imagination when assessing a patient's orientation in certain situations. Asking every patient who, when, and where they are is not always appropriate. A more creative approach is sometimes necessary. When assessing a patient's orientation, care providers should first introduce who they are and then ask their patient their name. The care provider should then ask the patient what happened or what is wrong. If at any point the care provider gets the impression that the patient's responses are inappropriate or questionable, time and place questions are then indicated. When assessing LOC and orientation, it is important to know what a patient's baseline mental status is. Although the patient may present altered, this current condition may be normal for them. For example, some elderly patients living in assisted care facilities will often know their name and where they are, but they may be out of touch with time and current events. Elderly patients who suffer from dementia may also be unable to recall time or place. It is in these instances that an inappropriate response is typical or normal for that patient. In these situations, ask caretakers or family on scene if this confusion is normal. Once we have established the LOC and orientation, we can move on to addressing the patient's chief complaint. The chief complaint is simply the reason the emergency call was made, described in the patient's own words. First, consider the nature of the call from your dispatch information. Then simply ask your patient what is wrong in the context to the nature of the emergency. In some cases, the patient may not be able to provide a chief complaint, such as when the patient is unresponsive or otherwise unable to explain what is wrong. In other situations, friends, family, or caregivers may have initiated the emergency call despite the patient claiming that nothing is wrong. In those cases, the chief complaint should be obtained from whoever activated the 911 response. As we stated earlier in this section, the initial assessment is designed to detect immediate life threats. When performing the initial assessment, we organize initial care priorities by using the acronym ABC, which stands for airway, breathing, and circulation. The patient's airway is our first priority because if it is compromised, it can become immediately life-threatening due to the brain's need for a constant supply of oxygen. Without oxygen, brain cells will begin to die within minutes, so this step is crucial during the initial assessment. Remember, no treatment you will ever administer will make a difference if the patient cannot breathe. For conscious patients, conducting an airway assessment can be as easy as talking with them. If the patient is able to speak without difficulty, this indicates the airway is clear and the step is complete.
Sir, my name's Jim from the fire department. How are you feeling today?
I'm feeling real weak. I feel real tired. Just don't feel good.
Other times, the patient may have a reduced level of responsiveness. In this case, the care provider's assessment should consist of ensuring the airway is in an optimal position and that there are no objects or fluids within the airway that might compromise the movement of air to and from the lungs. Patients with a decreased LOC may exhibit with snoring or gurgling sounds, which may indicate the need for a manual airway maneuver, airway adjunct, or suctioning to ensure an open airway. When a patient is unresponsive, their ability to manage their own airway with a gag reflex in normal muscle tone is limited or lost. In these situations, the patient's airway must be manually opened in order to position the head in the most optimal manner for efficiency in breathing. For patients without evidence of traumatic injury, a head tilt chin lift is most appropriate. For patients with evidence of traumatic injury, a modified jaw thrust should be initiated so that the airway is opened without manipulating the C-spine. In these situations, EMS personnel must maintain a jaw thrust until the airway is secured by other means. Both the head tilt and jaw thrust pull the base of the tongue away from the back of the airway. The tongue is the most common airway obstruction in the unresponsive patient. When done correctly, the head tilt chin lift and jaw thrusts have the added benefit of reducing the amount of resistance within the upper airway, thereby increasing the effectiveness of spontaneous or assisted ventilations with a BVM. Simple adjuncts can be used to further assist in maintaining an open airway, such as the oropharyngeal and nasopharyngeal airways when indicated. The care provider should also anticipate the need for more advanced interventions, such as in the presence of burn injuries to the upper airway. Evidence of such situations may indicate the need for early intubation due to the risk of edema closing off the upper airway and making later intubation attempts difficult to impossible. When assessing for breathing, the care provider should first consider if the patient's breathing is adequate or inadequate. During this time, you are evaluating the rate and depth of the patient's breathing cycle in order to determine the patient's minute volume. A patient can fall into one of four categories when assessing breathing: normal breathing, respiratory distress, respiratory failure, and respiratory arrest. Normal breathing is a ventilatory effort that is free of any distress, and for adults, typically will fall within a range of 12 to 20 breaths per minute with adequate depth. For alert and oriented patients with normal breathing, no actions may be required. Respiratory distress is marked by the elevated level of work required to overcome an increased resistance within the airway. The rate is typically increased in shallow relative to the level of the patient's distress. Overcoming the increased resistance within the airway is accomplished with accessory muscle use and an increased rate or work of breathing. Here you can see a patient in respiratory distress. Notice the increased work and use of accessory muscles to breathe. The next category is respiratory failure. This is when the patient is no longer able to compensate for the increased resistance within the airway and the patient begins to become fatigued and lethargic with a rapidly diminishing LOC and a slowing of the ventilatory rate. This is an ominous sign of impending respiratory arrest. Here you can see a patient in respiratory failure. This looks a lot like respiratory distress, except notice the fatigue the patient is experiencing. This is due to the body becoming tired from its initial compensation. Lastly, any patient with no signs of respiratory function is considered to be in respiratory arrest. Here you can see a patient in respiratory arrest. Notice there are no signs of any respiratory function. Once the patient's breathing has been assessed, the appropriate level of oxygen therapy should be initiated based on the patient's need. This may include a nasal cannula for a patient with no to mild breathing difficulty. A non-rebreather mask should be used for a patient in respiratory distress who has adequate minute volume. Ventilatory support must be employed with a BVM for a patient in respiratory failure or respiratory arrest. As stated, patients in respiratory arrest will have no signs of breathing when opening the airway. Patients should be assessed for the absence of a gag reflex, which may indicate the need for an airway adjunct or advanced airway. During this time, the airway should be secured by intubation or with other advanced airway devices such as ETDLAs like the Combi tube or King Airway. When available, a pulse oximeter can be placed on the patient very rapidly in order to establish a baseline oxygen saturation percentage prior to oxygen therapy. This simple diagnostic tool can help to measure for the presence and severity of hypoxemia and the effectiveness of the oxygen therapy provided to the patient. Utilize this resource when available. However, do not use this device to determine the type of oxygen delivery. A patient in severe distress who is able to work hard enough to obtain a pulse ox of 97% needs high flow oxygen so that their work of breathing is reduced, which may slow their rate of fatigue. If trauma is involved and the patient is in respiratory distress, a quick assessment of the patient's neck and chest should be conducted in order to rule out serious injuries that may be interfering with the patient's respiratory function. Injuries that may negatively affect the patient's breathing include, but are not limited to, sucking chest wounds, flail segments, or tension pneumothorax. The final step of our initial ABC assessment is circulation. This assessment consists of checking for and controlling any life-threatening hemorrhage, assessing for the presence of a pulse, as well as its rate, rhythm, and quality, and finally, checking the skin for its color, temperature, and condition. First, if severe bleeding is found, it should be immediately controlled with direct pressure. After assessing and controlling any severe bleeding, check for a pulse. While assessing for the presence of a pulse, the care provider should also consider whether or not the pulse is regular or irregular, fast or slow, or whether it is strong or weak. When checking for a pulse, first palpate the radial pulse at the patient's wrist. If a radial pulse is felt, the patient's systolic blood pressure is more than likely at a minimum of 80 millimeters of mercury. If a radial pulse is not found, the care provider should then check for the presence of a carotid pulse at the neck. If a pulse is felt at the carotid, the patient's systolic blood pressure is more than likely at a minimum 60 millimeters of mercury. Typically, for any unresponsive patients, it is recommended that the care provider directly feel for a carotid pulse. If the pulse is absent, the care provider should immediately begin chest compressions. Follow your local CPR and ACLS protocols applicable to your licensure level. The last step of circulation subcomponents is to assess the skin for its temperature, moisture, and color. Peripheral vasoconstriction decreases peripheral perfusion to the skin early in shock, causing cool, moist skin that can be pale, ashen, cyanotic, or blotchy in color. This is an example of the importance of inspecting the skin conditions during your initial assessment. If your patient shows signs of circulatory compromise, treat for shock by elevating the patient's legs, if injuries do not prevent you from doing so, in order to support venous return to vital organs. Also, keep the patient warm in addition to providing high-flow oxygen, and prepare for rapid transport as you continue through your assessment. A care provider at their discretion can anticipate and treat for shock based on the mechanism of injury and their general impression of the patient. But remember, in the early stages of blood loss, obvious signs of shock may not be present. The initial assessment ends with EMS personnel making a decision regarding the status of the patient's priority and speed of transport. The care provider should determine the patient's priority based on the information collected during the scene survey and initial assessment. Patient priority has 4 levels within which a patient can be categorized. The first is priority 1, followed by a priority 2, 3, and 4. Often, this is apparent during the scene survey due to a severe mechanism of injury. A priority 1 is the highest level of urgency and indicates an unstable patient in need of immediate transport to the nearest appropriate facility. Priority 1 patients are typically those in cardiac arrest and those whose complaint or injury has been identified as potentially life-threatening, either by protocol or assessment. A priority 2 is a patient whose condition has the potential to rapidly deteriorate. Therefore, on-scene time should be kept to a minimum. Most patients who have been identified as priority 2 are typically categorized as a 2 due to the high risk of the patient quickly becoming a priority 1. A priority 3 is a patient whose condition is considered stable, and so the urgency to rapidly initiate transport is low. All patients that are not suffering from any life threats are typically categorized priority 3. Finally, a priority 4 patient is a patient who is deceased. Review your local protocols for further information regarding priority 4 patients. When determining transport priority, the care provider should also consider the most appropriate destination hospital based on the patient's condition and underlying complaint. Base your decision on your local protocols and the patient's condition. This decision will help the patient after you leave the hospital. Taking them to the most appropriate facility provides the patient with a greater opportunity for the best possible outcome. After you have determined patient priority and established a transport decision, you have completed your initial assessment. Let's quickly review the initial assessment components. First, obtain a general impression of your patient by synthesizing the patient's presentation, the context the emergency has occurred in, and the social group the patient belongs to. Next, evaluate the patient's level of consciousness and determine if the patient's current LOC is normal for them. Once LOC is established, ask the patient about the chief complaint. Remember, the chief complaint is simply the reason the emergency call was made. Next, evaluate the patient's ABCs. At this point, you should take any corrective actions necessary to mitigate life threats against airway, breathing, major hemorrhage, or circulatory issues that are apparent. The last step on the initial assessment is to evaluate all the information you have gathered during that time and make a decision regarding patient priority and transport destination. Every emergency scene is unique, and the care provider needs the ability to adapt in order to be successful in their rescue attempt. Adaptability arises from a deep understanding of the guidelines that underlie the steps that were presented in this video. If we as care providers don't just know the steps and their order, but understand the role of each step presented today, their importance, and what they seek to accomplish, then we will be capable of adapting our patient assessment to each unique emergency situation and provide highly effective professional care for those in need of our services. Remember, your treatment is only as good as your patient assessment. That completes part 2 of American CME's patient assessment training video. Thank you for watching and have a great day.